Epiglottitis creates a rapid, lethal obstruction. Left untreated, it can easily suffocate a pediatric patient in mere hours. Formally, this is an acute bacterial infection specifically targeting the supraglottic structures of the upper airway. While it can occur at any age, children between 2 and 8 years old are the most vulnerable. Look at this clean 3D vector model of a healthy pediatric airway. Notice the normal, unobstructed spatial relationship between the trachea, larynx, and supraglottic space. The bottleneck happens right here, at the epiglottis. This shield is the primary infection site, soon becoming the physical obstruction. Understanding this specific anatomical bottleneck is the only way to comprehend the uniquely restrictive management protocol. Before widespread pediatric vaccination efforts, this disease cast a very different shadow over hospital wards. Historically, the common organism responsible for this airway crisis was H. influenzae type B, or Hib. The introduction and widespread adoption of infant immunizations against Hib effectively neutralized this primary pathogen. But the eradication of Hib did not eradicate the disease itself. Today, S. aureus and group A Streptococcus are the commonplace causes. While the bacteria has changed, the resulting mechanical airway emergency remains identical. Even with a vaccinated patient, the risk of rapid, total obstruction is just as acute. Returning to the pediatric airway model, watch the onset of an acute bacterial infection. A rapid bloom expands across the epiglottis, demonstrating severe tissue swelling. The inflammation then travels downward, visibly thickening the airy epiglottic folds and arytenoids, mechanically pinching the airway shut. This sudden, severe internal inflammation maps directly to the patient's first major systemic sign, an abrupt onset of high fever, typically spiking up to 40 degrees Celsius or 104 Fahrenheit. The localized swelling also creates a severe sore throat and profound difficulty swallowing. Because swallowing becomes impossible, drooling emerges as a primary, classic external indicator of the internal blockage. As the glottic opening physically narrows, the child pulls air through a shrinking gap, generating stridor, a high-pitched, turbulent breathing sound. This labored breathing may be accompanied by physical retractions as the child's chest wall struggles against the mechanical obstruction. Desperate to compensate, the child exhibits extreme anxiety and restlessness. They will instinctively sit upright and lean forward to force airflow into the lungs. Every behavioral cue, from the drooling to the tripod posture, is a mechanical consequence of a rapidly closing anatomical door. Identification of the disease requires extreme caution. While a diagnosis is necessary to begin treatment, the standard methods of gathering that information can trigger a fatal airway collapse. Routine procedures like venipuncture must be avoided. The resulting agitation can trigger fatal laryngeal spasms. Checking the patient's Hib immunization status is a vital first step in the non-invasive information gathering phase. The safest initial imaging route is a lateral neck X-ray. We look for gross anatomical abnormalities without physically touching the airway. Notice the pulsing outline tracing the enlarged epiglottis. This is the classic thumb sign, the definitive radiographic indicator of a dangerously swollen epiglottis. Direct visualization via nasal fiber optic laryngoscopy can confirm the diagnosis, but it requires extreme caution. Only a highly skilled operator should attempt laryngoscopy due to the severe risk of triggering total obstruction. To substantiate a bacterial infection, clinicians use a complete blood count with differential. Here, the white blood cell bar shoots upward. Drilling down, we look for a left shift, a sharp increase in bands or immature white blood cells. In these cases, confirmation relies on external imaging and strictly controlled visualization rather than the standard physical reflexes of the clinic. Treatment follows a rigid algorithm. On this flowchart, the baseline medical requirement illuminates first: continuous respiratory and cardiac monitoring, tracking SpO2 levels. From there, we move to initial supportive medications, antipyretics for fever, and mild sedation to reduce anxiety. For respiratory management, initiate supplemental oxygen therapy to keep the SpO2 strictly above 90%. And there is a critical rule regarding broad-spectrum antibiotics, like cephalosporins. They are recommended for a 7 to 10-day course, but only after securing the airway. Clinicians must constantly watch for late signs of impending respiratory failure, such as extreme lethargy, hypotonia, and cyanosis. A decrease in breath sounds as the obstruction worsens is an ominous indicator that acute arrest is imminent. If acute respiratory arrest strikes, manual ventilation with 100% oxygen must immediately precede highly controlled nasotracheal tube insertion. This fiber optic-assisted nasotracheal intubation must occur under strictly controlled conditions, such as rapid sequence intubation. If intubation fails and airway obstruction persists, the ultimate failsafe kicks in. The clinician must immediately recommend a surgical cricothyroiditis. The entire treatment algorithm is a delaying tactic designed to keep the patient calm until definitive advanced airway control can be established. Epiglottitis remains a rapidly progressing infection capable of causing death in hours. While infant vaccines defeated Hib, S. aureus and Strep A have seamlessly taken its place. Clinicians must recognize the diagnostic triad: the abrupt onset of high fever, difficulty swallowing with drooling, and the presence of stridor. Remember that the thumb sign on a lateral neck X-ray is the safest method of anatomical confirmation. The absolute rule of management is to minimize patient agitation at all costs by avoiding venipuncture and blind airway exams. Surviving this disease requires suppressing the reflex to act invasively, prioritizing pure anatomical preservation over standard physical medical assessments.